Severe combined immunodeficiency. Severe combined immunodeficiency, or SCID, is a group of genetic disorders resulting from profound impairments of T-cell development or function. Patients with SCID have absent humoral and cellular immunity. There are numerous genes that have been identified as causing SCID, which can be either X-linked or autosomal recessive in inheritance. X-linked SCID due to mutation in interleukin-2 receptor gamma is the most common cause of SCID. Infants with SCID are at significant risk of severe and life-threatening infections from viral, bacterial, fungal, and opportunistic pathogens. Some common pathogens include cytomegalovirus, Epstein-Barr virus, varicella, respiratory syncytial virus, parainfluenza 3 virus, adenovirus, mycobacteria, Candida albicans, and Pneumocystis jirovecii. Babies with SCID are often born appearing healthy. Affected infants usually present in the first few months of life with pneumonia, diarrhea, failure to thrive, thrush, and sepsis. Some infants can present as Omenn syndrome with an erythrodermic rash, lymphadenopathy, diarrhea, and failure to thrive. Often, the skin rash may be mistaken for eczema that does not respond to topical steroid therapy. Some infants can present with a similar rash and/or liver involvement from maternal engraftment. In this case, maternal T cells acquired pre- or perinatally are present in the infant's circulation and cause a graft versus host disease reaction. Some red flags for SCID include the presence of an opportunistic infection, failure to thrive, absence of palpable lymph nodes, and a narrow mediastinum on chest X-ray, which could represent absence of a thymus. Blood work often reveals lymphopenia and undetectable IgG, IgA, and IgM levels. Further investigation of the immune system will often demonstrate absent or low CD4 and/or CD8 T-cell numbers, absent T-cell proliferation to mitogens, and absent or low T-cell receptor excision circles. Keep in mind that infants with Omenn syndrome may have normal or elevated lymphocyte counts, eosinophilia, and a high IgE level on their blood work. SCID is a medical emergency, as it is fatal in the first year of life unless treated. Early recognition and treatment is key. The diagnosis of SCID is based on the clinical presentation and absent or markedly reduced T-cell function. Secondary causes of immunodeficiency should always be ruled out. The management of children with SCID includes treating infections aggressively, protecting the child, and definitive therapy. Cultures and virology from the blood, stool, and respiratory fluid should be sent. A high suspicion for Pneumocystis jirovecii infection should be maintained and may require a bronchoalveolar lavage for diagnosis. Serological testing is unreliable in these children due to their dysfunctional humoral immunity. Infants with SCID should be placed in protective reverse isolation, ideally in a room that has positive pressure and laminar airflow and a HEPA air filter to minimize exposure to infections. The infant should be started on prophylaxis against Pneumocystis jirovecii and be given intravenous immunoglobulins. Viral and fungal prophylaxis could be considered. All blood products should be irradiated and negative for cytomegalovirus. As well, the baby should stop breastfeeding or the mother's breast milk should be irradiated. The infant should avoid all live viral vaccines. Hematopoietic stem cell transplantation offers a curative treatment for SCID. In some cases, gene therapy or enzyme replacement therapy could be considered. Newborn screening for SCID is now performed on babies who are born in some states and provinces. This allows for early identification and treatment of babies with SCID, and hopefully allows them to receive definitive therapy before the development of life-threatening infections. If you have a child whom you suspect has SCID, please contact your local clinical immunologist immediately for advice on further investigation and management of the child.